My name is Dr. Sazgar. I don't know whether you know me well enough, so.
I know you well enough.
I am a clinical professor at the UCI Medical Center, and my expertise is in epilepsy treatment. I'm an epileptologist, and medically refractory epilepsy, especially women with epilepsy. So this is the topic that I'm passionate about, and that's what you're going to hear about today. Epilepsy in childbearing age. I'm going to talk about prenatal and postnatal counseling. With the prenatal counseling, I'm going to talk about oral contraceptives, the interactions with the anti-seizure medications, with the ASMs, what happens to seizures during pregnancy, do you get better, worse, what would be the percentage of seizures during pregnancy, use of seizure medications during pregnancy, benefits of folic acid, and also breastfeeding and seizure medications. So all of those on one side, and then postnatal care, which is just as important, the adjustment of seizure medications after the baby is born, the triggers of seizures in postpartum women with epilepsy, maternal seizure management, and developing a safe parenting plan for women with epilepsy, contraception, and then also postpartum depression and how that works for women with epilepsy. So we're starting with a case which is a patient, actually a patient of mine, with some modifications. This is a 28-year-old woman with a long-standing history of focal epilepsy. So this was an epilepsy that came from the right frontal area of the brain, and it was due to a congenital malformation of the brain. Basically, it's called cortical dysplasia, an abnormal tissue that she was born with. Otherwise, she was completely normal. She used to experience cluster of seizures around the time of her menstrual period. So about a couple of days before menstrual cycle started, and then throughout the period, maybe a couple of days after. So there was a surge of the seizures around that time. That's what we call catamenial epilepsy, when people have seizures that fluctuate with their hormones. And in the couple of years before she came to the epilepsy, she was completely stable, seizure-free. She was on a medication called trileptal with no problems with seizures anymore. Life was good. As soon as she started dating and she had a relationship, she was put on folic acid 1 milligram daily. And then she got married. She was on birth control when she was sexually active. And then all of a sudden, she comes to her neurologist and says, wait a second, my pregnancy test just came positive, and what's going on? I was on birth control, why did it fail? And then on top of that, she's having now a couple of auras after being seizure-free for 2 years. So she's worried, she has many questions. She's like, why am I pregnant? And what's gonna happen to the baby? And I'm on medication, should I stop it? Should I continue? What is going on? That brings us to the topic of women with epilepsy, that they face a lot of different challenges if you compare to all the population of men with epilepsy. There are certain things that women deal with that are specific to their gender and to basically to being a woman. And this special concern starts from the time of puberty, when the menses start, to the time thinking about the birth control, conception, throughout the child-bearing periods, and then also comes with the child care, and then also, believe it or not, until the menopause, there are issues that are related to the seizures and menopause. This brings us to the fact that epilepsy is the fourth common neurologic disorder. It is basically 1% of population, no matter where in the world, have epilepsy, and half of those are women. So that means that about 1.5 million women in the United States are dealing with epilepsy. 24,000 of them give birth each year. And it is important to educate both not only the population but also the physicians who deal with women with epilepsy, because sometimes things that, and like, they're afraid of dealing with all those medications during pregnancy, all those things that they have to be aware of. So let's start with that, with the contraception and why there was a contraception failure. How do seizure medications affect contraception? There are some seizure medications that interact with birth controls, which means that there are some medications that if you're on them, it doesn't matter if you have birth control, an oral contraceptive and birth control can fail with those seizure medications. And this is the list. I will categorize them into the red zone, meaning that those medications, if you are on those medications, the oral contraception is going to fail. So these are the medications that people end up becoming pregnant even if they're expecting that birth control can really prevent pregnancy. So carbamazepine, cenobamate, clobazam, eslicarbazepine, these are like, you may know the other names for it. These are the generic name, so like trileptal, Aptium, phenobarb, phenytoin, primidone, and rafinamide or Banzal. So these are the medications that if you're on, you need a second method of contraception, you need a barrier method, something else, because the birth control is not the answer there. The yellow zone is like these medications. There are only 3 medications, felbamate, prampanel, and topiramate, that at a low dose they're okay, but if you increase the dose, the contraception is going to fail. And then there is the green zone. So there are certain medications that are okay if you take them, like with clonazepam, etosoximide, gabapentin, some of the, like lamotrigine, levetiracetam, some of the most common things that people are on, zonisamide, even with valproic acid, there's not going to be any, there's a lot of other problems, but no contraception failure. So the green zone, meaning that you're okay to be on contraception if, and it's not going to fail. So in our patient, the very first thing is that trileptal or oxcarbazepine is one of those red zones. It is a medication that can induce the liver enzymes, meaning that this patient should have been on some other birth control rather than the oral contraception, and that's why she's pregnant. So there could have been some birth control medications, they have higher estrogen. And in that case, like if they have more than 50 microgram of estrogen in them, it can still be okay and not fail. But what would be the problem then? The problem is that we try in birth control, we try low estrogen for a reason. The higher the estrogen content, the higher the risks that are like the blood clot and all other heart issues, everything else can be. So that's not really a good option if you use a contraception with the higher amount of estrogen. Medroxyprogesterone, the Depo-Provera injection, that's one way that can, is more of a permanent, every 3 months you have to repeat it, but that can basically stop the menstruation in some people, and it can actually be a good method of contraception. IUD would be the method of choice of epileptologists. This is a method, like basically there are 2 different types of IUDs, either with progesterone. There are a bunch of them, Mirena, Liletta, Kylena, Skyla, those are all the ones that have the progesterone. And then there are IUDs that are copper IUD, and those are effective, but they don't have the hormonal part. If my patient has catamenial epilepsy, if they have the epilepsy that fluctuates with hormone, I usually tell them to use the one with progesterone. If they don't have catamenial epilepsy, then they can use any of the IUDs. So specifically with lamotrigine, you have to be careful, because if you are on lamotrigine, the moment you go on anything that has estrogen can bring down the amount of lamotrigine in your blood. So the patient can have recurrence of seizures if they are controlled. All of a sudden, if they go on birth control, they have to let the neurologist know, because the dose needs to be adjusted. The dose of lamictal needs to be adjusted. Otherwise, the seizure is going to recur because the level drops. Also, in people who become pregnant, lamotrigine drops really rapidly. So you have to keep up with your level that you had before pregnancy in order to be able to have the same seizure freedom during pregnancy. So what happens to seizures during pregnancy when people become pregnant? As I said, 24,000 women with epilepsy every year become pregnant. And the seizure frequency can go 3 different ways. So one is that in about the majority of patients, there's no change in the seizure frequency. 55% may have the same, like if they're controlled, they're going to be controlled during pregnancy. If they're not controlled, they're going to have the same number of seizures. But about 20 to 35% can have worsening of their seizures during pregnancy. And only about 10% can have improvement of seizures during pregnancy. There was a European registry for people who became pregnant and who were on seizure medication. 67% of them, we call that Europe, that's the European Pregnancy Registry for patients with epilepsy. About 67% of women with epilepsy who became pregnant actually they remained seizure-free, depending on what their seizure control was before pregnancy. 15.2% had generalized seizure during pregnancy. And interesting thing is that if you have primary generalized epilepsy, the kind of epilepsy that are both sides of the brain fire at the same time, the non-focal ones, those type of epilepsy, the chance that you have a better pregnancy is higher with them. There's about 58.2%. And the best predictor of not having a seizure during pregnancy is that 9 to 12 months before you become pregnant. If your seizures are controlled before pregnancy, chances are that you are going to be controlled during pregnancy as well. How about people who have catamenial epilepsy, who have fluctuations of their epilepsy with the hormones? What happens if they become pregnant? It's actually good news for them because these people, when they studied them, this is a study published in the Journal of Neurology in 2014. They followed 59 people with catamenial epilepsy who became pregnant, and then 215 people who had epilepsy, but their epilepsy was not catamenial. And they found that almost 80%, 79.7% of patients with catamenial epilepsy were seizure-free during their pregnancy. And about 50.8% had better outcome, better seizure control during their pregnancy, which is great, as opposed to the non-catamenial that was about 20%. So huge difference, and that means that at least there's a part of good news for people who have catamenial epilepsy, that if they become pregnant for some reason, that hormonal changes work to their favor, and they may be seizure-free during pregnancy. So it is a predictor of better outcome. What would be the cause of seizure recurrence during pregnancy? Well, number one is that when patients are referred to me, the moment that they find they're pregnant, they either stop their seizure medications or they lower it, or their neurologist or somebody outside tell them to, okay, lower it and then go to this appointment. That's a shame because that lowering and that stopping the medication is number one cause of seizure recurrence. And once you have a seizure when you're pregnant, there is more harm to the baby from having that seizure. Sleep deprivation, the anxiety that comes with becoming pregnant, finding out that you're pregnant. The increased estrogen to progesterone. Estrogen is the bad hormone, the progesterone is the good hormone for seizures, at least. The estrogen to progesterone increases during pregnancy, and then there can be more problem with seizures. And then the body grows, all these hormones, it makes the amount of medication to drop, especially with certain medication during pregnancy, and that could be one of the reasons that the seizures can recur. There is more dramatic reduction in the amount of medication, even if they don't stop the medication. Even if you are on the exact same dose of medication, with lamotrigine, with oxcarbazepine, phenytoin, phenobarbital, and Keppra, levetiracetam. With these medications, there is more chance that you have a higher drop in the levels. So what do epileptologists do? they measure what the level is before pregnancy, measure it a couple of times, and then during pregnancy, we try to catch up. We try to do every month levels of the medication and make sure that we match the pre-pregnancy level of those medications. And we have to follow them very, very closely. In our patient, remember that when she became pregnant, all of a sudden she started having some auras. The auras was because the oxcarbazepine, the trileptal, dropped in her blood. When we measured it, we found out that it is much lower than pre-pregnancy level, and we had to adjust it. So the dose was adjusted during pregnancy, and basically sometimes you need to do multiple adjustments. So why would we recommend patients to stay on seizure medication? Why not just to let people have seizures? What happens with seizures if you have it during pregnancy? Well, in women with epilepsy who have seizures, when they follow and see what happens to the baby, there is more risk of preterm delivery. There is more risk of low birth weight with these babies. The more seizures a mom has, the lower the IQ of the baby. So during pregnancy. So it's actually one of the predictors of IQ in the baby is not having those seizures during pregnancy. If you have multiple seizures, and again, babies can be small for gestational age, but it's kind of obvious. Like if you have cutoff of oxygen to the baby through placenta, when you have a seizure, that cutoff of oxygen and blood to the baby can have consequences, and that is not even like related even to seizure medication. This is a seizure itself can cause all of these. So stopping seizure medication is not an option if somebody has active epilepsy and they become pregnant. It is actually safer for them to be on certain medications as opposed to stopping those medications. When I counsel my patients, I tell them pregnancy is a risky business. If somebody is completely normal and they're young and they don't have any medications, there is still about 2% risk that the baby may have a major problem. So 98% chance that everything is going to be fine, and 2% chance that the baby can have a heart problem, a brain problem, what we call malformation of the baby. So that is in general population. This is some risk that is out there. And unfortunately, medicine has not gotten to the point to make that risk go away. So what happens if you have epilepsy or if you are on seizure medication? That risk is slightly higher. It's about 4 to 6%. So usually I tell my patients that there's a still 96% chance that you're going to be okay, but there's 4% risk during pregnancy if you are pregnant. Now, depending on the seizure medication that you're on, then that risk may change. It may be higher or it may remain the same. There is another risk of spina bifida. That's when the neural tube in the backbone, it doesn't close properly, and that can cause a lot of issues. And that is one of the reasons that we put patients on folic acid when they are on childbearing age, because that prevents neural tube defects. That basically it prevents the spina bifida. Valproic acid has a higher risk of causing a spina bifida, and carbamazepine has about 0.5 to 1% of causing that. So where do we get our knowledge about all these seizure medications during pregnancy? How do we know which one is safe and which one is not safe? It's through pregnancy registries. So we urge patients who become pregnant to sign up with one of these registries, and there are many of them. There is the European one, there is the North American one out of Massachusetts, there is the UK one, there is the Australian one, many different registries. We ask them that please register with these pregnancy registries, because next time that you become pregnant, I have that much more information to give you, or to other moms to tell them how safe this medication is. So basically they follow these people who become pregnant, who are on this medication, and they follow the babies. and they look at whether there is any abnormality of the babies and whether they are they safe. So this is the results of North American Pregnancy Registry, and as you see, they started in 1997, and last night I looked up again, and there was an update in October, so it is the most up-to-date information that you can get, October of 2023. So the pink one on the left side, on the corner, 1.2% was basically people who weren't on any seizure medication during pregnancy, people who did not have epilepsy. So 1.2% was the rate of these babies having abnormalities, having congenital malformation, abnormal heart, abnormal brain, those kind of things. And then these are basically the name of the medication: lacosamide or Vimpat, zonisamide or Zonegran, gabapentin, oxcarbazepine, clonazepam. This is Keppra, levetiracetam, lamotrigine. From here up, these are bad. So any like the pregabalin, phenytoin, carbamazepine, topiramate, phenobarbital, and valproic acid. You see the rate is up to 9.2%. So if somebody becomes pregnant, I'm sorry, let me. So these are people who are on these medications, and this is a risk of having an abnormal child and a child that has those abnormalities. Phenobarbital is about 6%. With the topiramate is about 5%. So these are high risk. Anything above 2, remember 1 to 2 is the normal general population. The good news is that there is a lot of medications, starting with lamotrigine and levetiracetam down the road. If you look at the oxcarbazepine, gabapentin, zonisamide, they're actually pretty comparable. So if my patient is on oxcarbazepine, if my patient is on lamotrigine, I tell them, you know what, so far so good. We have, I think with lamotrigine we have more than 2,000 pregnancies. With zonisamide is about 200, 300 pregnancies. So the numbers are not exact, like the same, depending on how many people registered with them, but at least we have some information. With lacosamide, the risk is 0 there, but there were only 88 patients. So we still don't know for sure. This is something that as we have more and more numbers, then the percentage may change. But so far so good, and that's what we have with these medications. So this is the North American Pregnancy Registry. There is a lot more in the world. There's the UK, there is the European, other ones. This shows how practices change based on what we find in those registries. If you look long time, like initially, lamotrigine had a peak. A lot of patients were just on lamotrigine, but then as soon as we find out it's hard to control lamotrigine during pregnancy, it is really a pain. We have to every month increase the dose of lamotrigine, and a lot of these pregnancy registries, we don't know whether the higher dose is going to be more problematic or than the lower dose. So if you look over years, like when you get to 2021 forward, you see that people are prescribing more levetiracetam, more of the Keppra, almost the same at the same level of lamotrigine, and then you see the topiramate had a peak, but then people found out that it's harmful, so now they're not, it's dropping. People know that they shouldn't be on that during pregnancy. And then the gabapentin and zonisamide prescription are going up a little. So the other interesting thing that people will ask is that what happens to the IQ of the baby when they are born if you use seizure medications during pregnancy. And our information is based on a study called NEED, Neurodevelopmental Effect of Seizure Medication During Pregnancy. This is by Dr. Mader and colleagues that they're following people. They were on monotherapy, meaning that they were on one seizure medication during pregnancy, so either lamotrigine or carbamazepine or valproic acid. And then they followed the babies for their IQ at 3 years of age, at 6 years of age, and they found out that the predictors of low IQ in the baby were 4 things. One was if mom was exposed to valproic acid. So none of those other medications caused low IQ, but valproic acid did. Low maternal IQ, obviously, like if you're not that smart, your baby, there's more risk that the baby also is going to have lower IQ. The other thing is number of seizures during pregnancy. So remember that it's important to control those convulsive seizures during pregnancy. The more seizures you have, the lower the IQ of the baby is going to be. And polytherapy, being on more than one medication during pregnancy, those are the 4 risk factors for somebody having developmental issues, cognitive issues with the baby. So with our patient, what happened? Our patient was on oxcarbazepine, and so far, as you saw, the risk was about 2% or less with the oxcarbazepine, so she stayed on that medication because the risk was not alarmingly high, and then she continued on folic acid during the pregnancy. What about folic acid? What is it? And I just touched base on that a little. This is basically a supplement, like a vitamin, that is important and is essential during baby's development. So it's important in the growth of tissue and especially the nervous system, the neural tissue of the brain tissue, basically, of the baby. Overall, by the CDC, the Center for Disease Control, says that anybody in the population, all women, should be taking at least 0.4 microgram of folic acid. Some of the prenatal vitamins have 0.8 microgram of folic acid when they are expecting to become pregnant. Now, this is interesting because 50% of pregnancies in the United States are unplanned. So everybody should be on folic acid if there is a chance that they become pregnant. And it's not specific to epilepsy patients. So there is no specific study in patients who have epilepsy. There is no study that says, oh, more folic acid is better, or they should be taking more folic acid, as long as they take a reasonable amount, which is about up to 1 milligram of folic acid. There was a systematic review by one of the physicians, Dr. Wald, who basically looked at the dosages of folic acid. Up to 5 milligram of folic acid gave about 85% protection from spinal bifida, neural tube defect. But there was a population study in Spain that came and that kind of alerted us to the fact that the more may be more harmful. So there is a specific dose that is okay and it's good to take, but like any other vitamins, if you take mega doses, it doesn't mean it's better. People can get sick from high doses of supplements and vitamins. They looked at folic acid supplementation of 1 milligram and then more than 1 milligram. And they found that there was more risk if the dose was more than 1 milligram. There was more risk of small for gestational age, so the babies were not getting to the actual weight that was healthy. And there was also some cognitive developmental issue with those babies when they followed them at about 4 or 5 years after they were born. So the more is not the merrier. The more folic acid doesn't, if you don't have any evidence, then it's better. Unless the patient is on a medication that can cause trouble with folic acid, like valproic acid, like carbamazepine, like dilantin, phenytoin. Those are medications that actually make the folic acid lower in blood. In that case, you may have a case to make that maybe a little more folic acid is helpful. Overall, the message is I don't put my patients on more than 1 milligram of folic acid daily, and hopefully my patients are not on those medications when they become pregnant. I don't usually, it would be not impossible, but unless this is the only medication that makes them seizure-free, I usually switch them to something that's safer before they become pregnant, if I have time to do that. So pregnancy recommendations is that you follow up with high-risk obstetrician, you follow up with an epileptologist, ultrasound the first trimester, ultrasound again on the 16th week when they can actually do the anatomy of the baby and find out if anything is wrong. And I usually also recommend AFP testing or amniocentesis when they can, especially if maternal age is advanced. In combination, all of these can detect 95% of abnormalities of the baby even before they are born. Other pregnancy recommendation is that, if possible, I ask people to refer the pregnant patients before they become pregnant, when they're planning pregnancy, because by the time that they're pregnant, there's not a whole lot I can do. If they come to me, they're already on valproic acid, I cannot really make changes because that would be probably too late to make changes. It's too risky to try to make that change when they're already pregnant. So, and try to simplify their seizure medications before they become pregnant. So try to see whether they can be seizure-free only on one medication rather than 3 or 4 medications altogether. And then during the pregnancy, obviously, I will follow the levels and I will find out whether there is any adjustment needed. How about breastfeeding? So that's the last, that's like after the baby was born. What would be the recommendation for breastfeeding? Well, everybody knows breastfeeding is good because it reduces the infant mortality, it boosts the immune system of the infant, there's less risk for diabetes, less risk for a lot of other diseases if you breastfeed your baby. So moms, they know that breastfeeding is good. The recommendation is that if there is no other contraindication, women should breastfeed for at least the first 12 months of the baby's life. But our main information on breastfeeding in patients who are on seizure medication comes from that MONID study. That's the same study that we were talking about, neurodevelopmental study. They actually followed the women who were breastfeeding. There were 351 women enrolled, 345 infants. There were 7 seizure medications that they were studying: carbamazepine epoxide, that's the metabolite of the carbamazepine, oxcarbazepine, levetiracetam, that's the Keppra, lamotrigine, topiramate, valproic acid, and zonisamide. So a lot of seizure medications. So these are women who are breastfeeding. They measure the amount in the mom and at the same time in the infant after the breastfeeding to see how much of it, what's the level in the infant. The good news is that 49% of these infants have levels that were lower limit of detection. It was not even detectable. And we're talking about these women were pregnant taking these medications during pregnancy. So the exposure is 100% when you're pregnant. But the breastfeeding, it basically drops by the time that it gets to the breast milk and gets to the bloodstream of the infant. Overall, the infant to mother ratio was somewhere between 0.3% to 44.2%. So the conclusion was that the level in the infant is not either as detectable or it was low enough that a lot of us as epileptologists, we recommend to stay on basically to continue breastfeeding, and it is actually more beneficial for the baby if the mom breastfeeds despite being on seizure medication. So that's usually another, like the next question that I'm asked is that whether it's safe for me to do the breastfeeding. Our patients gave birth to a healthy baby girl, continued to breastfeed for about 6 months, and there was no problems. And initially, after she gave birth, she had some auras, and because of a sleep deprivation, because of all the hormonal changes, so we had to actually make sure that her level of medications are adjusted. And then she chose to be on IUD so that next time that she wants to become pregnant, at least she plans it rather than being surprised. So during pregnancy, she was treated with oxcarbazepine. The dose was increased gradually from 600 twice daily to 1200 twice daily. She had no more orals during pregnancy, and she gave birth to a beautiful baby girl, and the routine postpartum care was discussed with the patient, husband, and with before they left. A week following delivery of her baby though, she reported that she had double vision, she had dizziness and lack of balance. So she's just feeling really out of balance. We did an oxcarbazepine level, and okay, so the baby is born, so the level is now too high for her compared to the during pregnancy. So during pregnancy we adjusted, and now we had to more quickly adjust the dose. She was on 1200 twice daily. We reduced it to 900. Remember, she was on 600 twice daily, but we kept it a little higher because, you know, right after the birth of the baby, she's going to be sleep deprived, she's going to be stressed out, there's a lot more risk for having seizure recurrence. So for her, we kept it a little higher, and then her toxicity symptoms resolved. So what happens to the seizure medication pharmacokinetics during pregnancy? We know that there is increased metabolism of that medication during pregnancy. Some of the seizure medications drop by more than 50% during pregnancy. Their glucuronidation is just another pathway in the liver that some of these medications are affected by estrogen, the amount of estrogen that is elevated during pregnancy. So basically there is a decline in the level of some seizure medications, levetiracetam, lamotrigine, oxcarbazepine, topiramate, and zonisamide specifically, they have a high drop. Interestingly, carbamazepine doesn't drop as much. So like, we don't have too many patients who are on carbamazepine during pregnancy, but they usually don't need any adjustment during the pregnancy. Clobazam, lacosamide, gabapentin, perampanel, valproic acid, those usually don't change, or we don't have enough information to say one way or the other whether they, like how much they change. So the up titration depends on specific cases during pregnancy. What's the algorithm? So what do we have an algorithm of what to do with these medications after the baby is born or during pregnancy? Normally before pregnancy we measure the seizure medication level a couple of times at least, and then as soon as they call and they say they are pregnant, we do send them for another, and these are trough level, meaning that it's a level in the morning before they take their morning dose of medication. And we try to play catch up, basically every month we are measuring the levels. Depending on how much it drops. If the drop is about 15 to 25, below 25%, we may wait before adjustment depending on the individual cases, but if it is more than 25%, we definitely adjust. And especially that's true for lamotrigine. Once pregnancy is over, it's another. Basically, I usually write a note to the obstetrician, do a level the day after the baby is born, and do it like a few days after the baby is born, usually 3 to 5 days, and then 2 weeks after, because that level can become toxic very, very quickly. Now, if I have already not done any adjustment, if the levels were okay during pregnancy, you don't need to drop it after pregnancy is over. But if I have gone up a lot on the medication, usually at least drop it by 25% right after the baby is born. And then after that, gradually, depending on the levels, we usually within the first 20 days, 21 days that the baby is born, we have to make all of those adjustments. And again, certain medications, we talked about that those medications, the oxcarbazepine, the levetiracetam, lamotrigine, they drop more rapidly during pregnancy. So the chances are that we have adjusted much more heavily, and the chances are that we have to readjust after the baby is born. Now, our patient was sleep deprived due to waking up multiple times. We are now going postpartum. We are now doing all of the prenatal consult, and then now what happens after the baby is born. So she she was waking up to breastfeed, and she was very stressed out. And after about 2 weeks postpartum, unfortunately, she had a seizure recurrence. As she was giving a bath to the baby fell in the bathtub, and it was a near-drowning accident. Fortunately, the husband was there, got in the room, rescued the baby, and luckily, the baby was okay. So what are the postpartum seizure triggers? Obvious, lack of sleep, the stress, the physical and emotional stress that comes, variable levels of seizure medications because everything, all the hormones are changing and the levels of the medications are changing. Missed medication. Mom usually wants to take care of the baby. They don't want to, they forget to take care of themselves. And that is, those are the issues with having, immediately postpartum having seizure recurrence. So the safety precautions are overlooked usually in counseling. These are like, you're not discharging just a mom. You're discharging a mom who has epilepsy. So the counseling should be accordingly. The obstetricians, people who do, like the nurses, everybody should know that there's some safety precautions that need to be done. The obvious thing is sleep deprivation. So try to pump the breast milk. If it's not, there's nothing wrong with that. Like put it in the fridge, ask somebody else to wake up and feed the baby if possible. Like if you're feeding the baby, make sure that the baby is secure, make sure that you're not holding the baby and standing, that it is at the floor level. And for older infants, usually if you're feeding, strap them to a high chair, but at the lowest level possible to do the feeding. There are certain types of epilepsy that are worse during the early morning hours. Juvenile myoclonic epilepsy, JME, that's one of the ones that they wake up and they're clumsy, they may drop things. With that type of epilepsy, sleep deprivation affects them a lot more than other types. So these patients, we have to tell them that it's absolutely important to avoid the sleep deprivation, and alcohol is another thing that can really affect this. And usually, like with those, especially those moms, we will tell them, in your case, it is absolutely important to get enough of sleep and make sure that you don't handle the baby in the early hours of the morning. Be careful, have some, ask for some help. And again, in women with epilepsy, I usually tell them don't give a bath to the baby if you're alone. If you want to give a bath, just do a cloth bath and then this separate container of water. And again, all the play and care activities to be done from the ground level. If you have multiple levels at home, you have to run up and down the stairs. Make sure the supplies are both upstairs and downstairs, so you don't have to keep running up and down for those supplies. And then there are other safety precautions. Do not carry the baby alone. If you have active seizures, use strollers that have special brakes. And keep, again, the supplies we talked about, keep the baby in playpen. Make sure they're secure. Always think about what if I have a seizure, and I am with the baby. And also safety harness for toddlers. Other safety precautions, put a message on the baby, say that this is the condition that you have, that if somebody finds you, they know exactly that this is that you could have had a seizure. Support groups are absolutely important to introduce the mom to the support groups and have a safety plan in place. In UK, when they asked moms that what is the important thing for you, what was, from all of the safety precautions and everything, what was the most important thing that you received, it was actually how to keep the baby safe, rather than seizure. They didn't care about like their own seizure or their own stress or their own sleep deprivation. That didn't matter as much, or the seizure medication levels and all that. They cared about the safety precautions. So those are absolutely important, and I will go over it with every single one of my patients before the baby is born, so that they are aware of that. And 86% of patients found that very, very helpful. Again, contraception becomes important. So once you give birth, doesn't mean that you can't be pregnant again. So that can happen, even if you're breastfeeding. So usually I send them back to the gynecologist to make sure that if it is IUD or some other method of birth control that they put that in place. And it's the same contraception that we talked about. So there are certain medications that interact. Remember the seizure medications that can fail contraception. So make sure that if they are on those medications, they receive IUD. And our patients basically went back and chose to be on IUD and then continued on folic acid. The last thing that I want to talk about is postpartum depression. Our patient became increasingly depressed after gave birth, because, especially after that bathtub accident. And she had difficulty adjusting with her new life situation. She had the fear that the seizure can happen again, and she was diagnosed with postpartum depression. What is postpartum depression? This is an actual psychiatric diagnosis based on the DSM-5 criteria. It happens within the 4 weeks of the baby being born. And normally in population, 9 to 13% have postpartum depression. What is it in patients with epilepsy? 27 to 39%. So very high level of postpartum depression in patients with epilepsy. And the features are depressed mood, irritable mood, loss of interest in doing things, going out, change in weight and appetite, insomnia, or like not being able to sleep or sleeping too much, loss of energy, feeling of worthlessness, and impaired concentration, and constant thinking of death and suicide. So the contributing factors, obviously, frequency and type of seizures. The more frequent seizures, the more likely that patient can have postpartum depression. Being on multiple medications rather than one medication. Socioeconomic status. People who are lower socioeconomically, they can't afford things, it's actually much higher in them. Unplanned pregnancy, if that pregnancy was not planned for. Previous miscarriages, and then also any stressful situation after the birth of the baby. It's important to have a multidisciplinary approach to patients with epilepsy, women with epilepsy. To make them independent, to make them actually be able to independently take care of that newborn, but safely. And it starts from that nurse and obstetrician when they are doing the discharge to all the epileptologists or neurologists who's taking care of them, the pediatrician. Everybody should be aware and on the same plan, because they all should know this is just not a person who just gave birth. This is a person with epilepsy who just gave birth, and they need to be aware of all of the issues. I know this was a long talk, but it's a very important one to make that care both before the birth of the baby and after. In conclusion, if proper recommendations are followed, usually the majority of patients with epilepsy give birth to healthy babies, and usually they are able and capable of taking care of their babies. The postnatal counseling of women with epilepsy is just as important as prenatal counseling. Without appropriate direction, people may feel abandoned. They may feel that they don't have the right tools to take care of their baby. Postpartum management is not just about medication level. There's a whole lot more involved in that, and there should be enough of support for the baby and mom. And that takes a village, that takes a multidisciplinary approach, that takes a lot of us to care for women with epilepsy. And I thank you for paying attention.
Have there been any studies to determine how pregnancy has affected someone's conditions relative to after, long term, as was before? Like, have there been changes, worse, better?
Oh, like not just during pregnancy, what happens after?
Well, after, like, does the pregnancy affect that?
In the majority of patients, if they are completely controlled in 9 to 12 months before pregnancy, they are going to be controlled during pregnancy. And that's not going to change after pregnancy either. So it's not, I know that I've had rare patients who have their first seizure during pregnancy. and they start having somehow that pregnancy. But that is really unusual. That that would be the time that they have their epilepsy started. But most people, whatever they were before pregnancy, they're going to continue with that unless there's more adjustment of medication or some other approach, intervention. Go ahead.
Is there any difference in the rate of infertility in women with epilepsy versus women without epilepsy?
It's a great question, and that is one of the things that we debate. We don't think that, based on the study by Page Panel, one of the big people in epilepsy, they did follow patients and questionnaires of people that what was the rate of infertility, and the infertility wasn't actually increased, but there's a lot going on in that. It's not just, the fertility is not just whether they're capable of having that. There's a lot of there's a lot of other things involved in the fertility. So whether you're in the mood to have sex because, if you just had a seizure, or whether the seizure medication is affecting that, or whether, so there is a lot of, I don't think that it is answered yet, and I don't think that we have the full answer for that. But again, the most recent study, they don't think that women with epilepsy are less fertile compared to other, but the fertility is not just there's a lot of other issues, social issues involved with that, and socioeconomic issues.
And then what about miscarriage rates? Is it increased if you have epilepsy versus if you don't? Are more people if you have epilepsy available?
I think that, but depending on because miscarriage sometimes is a genetic abnormality of the baby that is causing that. So people with certain syndromic epilepsy, they can have more miscarriages because of that. Sometimes there are certain syndromes that cause miscarriage that is more common in also patients with epilepsy, like antiphospholipid antibody syndrome, when they have blood clot tendency that causes miscarriage. That miscarriage could be higher, because the same people can have also epilepsy. So there is, if you have certain of those syndromes, yes, there is going to be a higher risk of miscarriage.
Thank you.
All right. Go ahead.
Hi. So my daughter, she struggles with epilepsy and casual epilepsy, and it took about 9 years for her to get diagnosed. When she got diagnosed, she was over 65, and she's the only female in California with this disorder. And now she only gets seizures associated with her menstrual cycle, so she's getting it a week prior, then between day 1 and day 4, then at the end of it, and then a week later. So she's averaging about 4 seizures a month, and it's all associated with her cycle. So I'm hoping maybe you can share some insight or perspective, what could be recommended to her neurologist. She's taking carbamazepine and Ompi regularly every day. She's adamant as a breakout seizure medication, but we just cannot.
She's on 2 medications that we call them enzyme inducing. Both of them can make the liver get rid of other medications. So a lot of times with catamenial epilepsy, with that, the treatment would be using some hormonal intervention.
Because none of the OCPs have worked because of the Tegretol, because of the carbamazepine.
Right. So it has to be a higher level of Depo-Provera or some sort of the injection.
We tried the Depo.
But it has to be more.
She was in the hospital 9 months out of the 12 months.
Yeah. So those are there's a whole that's a whole different talk on how to manage patients with catamenial epilepsy, which is a little different than the talk that I did. So you have to, it's individual, you have to find out whether if they can tolerate Depo-Provera, whether we should do it more often compared to instead of every 3 months, having every 10 weeks. But I have patients who don't tolerate, I have patients who had blood clot with that, or irritability, or just it doesn't work as well because they are on carbamazepine or clobazam or medications that can induce enzymes. There is certain clobazam itself sometimes can be used at a higher dose around the time of menstrual period to control the seizures. There's other medications that you can, I know, there's rescue medications that can be used during the time that the seizures are worse. Acetazolamide is one. There's not, the bottom line is that it's not perfect, and we don't have all the answers regarding what would be. What we have is what we have so far, and unfortunately it's not good enough for some patients.